morning, everyone, and welcome to this episode of the webinar for the Behavioural Implementation Science Intervention Center at the Yong School of Medicine. My name is Joanne Yong. I'm an adjunct professor at BISI, and I'm delighted to be here today with three eminent speakers to discuss today's topic, which will focus on the challenges of taking interventions that we might see as ideal in principle, effective in a laboratory setting, but challenging to put into place in real life. Now, this is the kind of situation we see every day in the healthcare setting, where what we do is try to take evidence-based research into the reality of the ground. But three of the most common challenges that we face are, firstly, things that work very well on paper, work reasonably well in laboratories with patients and volunteers, actually on the ground turn out to be ineffective, or in the worst possible case, have harmful effects. We also worry very much that interventions in the real world face populations that are very different across one another and also change over time. And so we want to talk today a little bit about effectiveness and efficacy. We want to talk about negative effects and negative spillovers, and we also want to talk about heterogeneous populations. Today, I'm also delighted to have with me then three speakers who bring with us a wealth of experience, both from the academic and research worlds, as well as the policy and practice worlds. And in the order in which they'll be speaking today, I'd like to introduce Adjunct Assistant Professor Serene Ko. Serene is a behavioral scientist, currently the director of BIT Singapore, where she leads domestic consultancy work as well as capability building across the region. Serene helped to set up the office of BIT in 2016 and has looked at multiple projects across multiple policy domain areas. In fact, over more than 200 behavioral projects, many of which are randomized control trials. Serene also works with capacity building and trying again to build the ability of systems to take up and put into practice these interventions. And so I'm delighted to open the webinar today by inviting Serene to give her thoughts on how we might think about efficacy and effectiveness in the real world setting.
So, as Joanne mentioned, a lot of what, as practitioners, we worry about is how, when we have established something as having worked in a lab or in a pilot setting, how does that look like in the real world, right? And so I think it's really important to set up the distinction between efficacy and effectiveness, which will segue really well into what Giuseppe and Uri are going to talk about later about spillovers and heterogeneity. But when we talk about efficacy, so efficacy is sort of like the capacity of an intervention to produce a desired effect under ideal controlled conditions, right? Where we're looking at something that has happened in the lab, where we have set out very clear parameters for participants to follow and adhere, or even in a field trial, a pilot field trial, where we have many resources in place to support our participants to follow a certain protocol. And so in a lab setting like this, or in a pilot setting, things happen in the way that we would like them to happen, right? And so whatever happens as a result of that, we say has shown the efficacy of an intervention. The effectiveness of an intervention, however, is how well the intervention works in real world practical settings. And that's what, a lot of what four of us on this call study a lot of is, okay, when we're looking at real people in real situations where you're no longer as in a controlled environment, what does that look like, right? When we have to juggle the expectations of the intervention with other demands of our life, where we have to like struggle with biases, we have external conditions like other people and other expectations. How does that then affect the way in which this intervention then has an impact on whatever behavioral outcomes we're looking at? And so the tension between establishing what works in the lab and then taking that and looking at the effectiveness of it in the real world, particularly in health, I think is a perennial challenge. And the two sort of like behavioral outcomes I'm interested in sort of like talking about, and I think very real for perhaps a lot of you on the call, mental health interventions and also weight management. So obesity or just anything with exercise or food choice. So in terms of mental health, I think the challenge that people have balancing efficacy and effectiveness is very often in a lab setting or in a pilot setting, participants in mental health interventions are recruited and therefore volunteer in many cases for the kinds of pilot trials that we see. And Joanne was talking about just now about like in the real world, profiles of people are different. And when it comes to health, people who volunteer for a program versus people who are mandated to attend a program are vastly different in terms of their motivation. And so when it comes to mental health, when we're working with volunteers who have signed up for a pilot, volunteers who have signed up for a lab trial, the reasons why they sign up already tell us that they are intrinsically motivated, right? And therefore, whatever effects that we see as a result of this trial, the efficacy of these trials are in part due to people who have volunteered for these lab trials and these pilot trials. And so when we then take this, so we say that we have established the efficacy of a mental health support program that has happened, let's say, in a university setting, we take that and we say, oh, it has worked for, let's say, university students. Let's scale this up, right? Let's see whether or not it is also effective the way that it was efficacious, effective, let's say, in all the universities in all the institutes of higher learning in Singapore. We're gonna see whether or not, or we're confident that it has worked in our pilot. It will therefore definitely work in the real world where we have scaled it up. Unclear, because now the people who are coming to these mental health programs don't have to. They're no longer bound by the protocols of a pilot. They are like, as I mentioned earlier, if they're students, it's a high stress environment, they have schoolwork, they have part-time work commitments, for instance, and the conditions under which this mental health program is now being scaled is no longer the same as it was in a controlled setting. And so the same outcomes that we might have seen, the same efficacy the program had in that controlled environment are not unlikely to play out the same way in terms of effectiveness because the external environment is no longer the same. Similarly for like weight management and food choice. Again, many programs that happen in a controlled environment when it comes to food choice assume or dictate that you follow a very clear protocol. Here's your portion size, here's what you have to eat, here are the exercise regimes that you have to do. And therefore, these programs have a very controlled setting under which they have to work, right? And so again, the efficacy part of it, and you can very easily see what happens when you translate that into real world, right? Where you are open to the very human biases of temptation. Present bias suggests that we are more likely to maybe eat a piece of cake versus go out for a run, where you're unlikely to see immediate returns on your effort. We all suffer from bandwidth tax, where on a very high stress day, for instance, you are more likely to choose the easiest thing, which is just to stay at home and veg out versus going out and actually doing something that's healthier for you. And so the salience and the impact of bias in a real world setting or in real time has probably a disproportionate effect on the way in which you respond to a weight management or food sort of like a food choice intervention in the real world, where we are more susceptible or we are more likely to give in to these biases in the real world, which then affects the effectiveness of these programs in the real world. And this is where sort of like behavioral science comes in, right? Where we balance the implementation science considerations of scaling something up in the real world with the behavioral science component, which is how can we then harness, right, these behavioral biases for good? The same behavioral biases that may lend you to, let's say, take disproportionate amounts of alcohol because when you're with a group, it's a party and you sort of like take more alcohol than you should. That same social influence can also be harnessed for good, right? So that we can make sure that the efficacy that we see in the lab can have similar, if not, well, as good effects in the real world. So like how can we harness behavioral insights, social influence for good, where we like instead of drinking together, we exercise together, right? Or like walk together, participate in programs together. And so how we can, and the point of the Center for Behavioral Interventions, Implementation Science Interventions is how can we combine the two, right? And I think that Yuri's going to talk a little bit about behavioral science and public policy later on, is using the powers of behavioral science, using our understanding about human behavior to then boost, right, the implementation aspects of scaling something up, such that whatever we see as being efficacious in the lab can also have at least some level of similarity in terms of effectiveness in the real world. So yeah, I'm going to stop there and just, let other speakers go on as well.
Thank you, Serene. I think that also has a lot of I have a lot of questions. I want to tell anyone in the audience, if you have questions, please feel free to start putting your questions in the Q&A. Please don't use the chat function. Place them in the Q&A section. We're going to let the speakers go 2 rounds, but we will come back to audience question and answer after we're done. I'm going to segue from that discussion to Professor Giuseppe Veltri. Professor Veltri holds a master's in social science research methods from the London School of Economics and a PhD in social psychology, also from the London School. Giuseppe has worked in many different positions in Europe, previously for the European Commission, and most recently was a full professor of computational social science and behavioral data science at the University of Trento, but now is a professor here with us at BISI at the National University of Singapore. And I'd like to invite Giuseppe to speak to us a little bit again about the topics really of heterogeneity in populations, and also if you have any other sort of reflections at the moment on what Serene has already brought up.
Well, thank you, Joanne. Good morning to everyone. I guess what I'm going to say follows nicely what Serene has introduced, because one of the biggest debates within the behavioral science community has to do, obviously, with efficacy of interventions. And in general, there are two sets of explanations that people are giving to the fact that sometimes we don't see the efficacy that we would like to see from the lab to the real world, or even in transferring from different settings, experiments that have been done also in the field. The first answer is usually related to the selection bias of treatments, meaning that we often test only a few treatments and we don't know, among all the possible treatments we could do, so the type of behavioral interventions we could do, which one is the best. So we pick some and we only test the relative efficacy of those that we have. And so people now are doing, the researchers within the behavioral community, they're advocating the use of these so-called mega studies, where you test a lot of treatments at the same time in order to find some kind of ranking of the treatments and find the ones that really are the best, and therefore increase the efficacy of your treatments, because you sort of exhaust the space of potential interventions. But the other answer to that is the issue of heterogeneity. Now, everybody who has done an RCT in behavioral science, or in general has to do with social science, knows that there's a lot of heterogeneity in all the effects or models that we use to explain whatever phenomenon. And so heterogeneity of treatment effects refers to the variability in how different subgroups within a sample or a population respond to an intervention or a treatment, just to clarify. So everybody recognizes that there is this heterogeneity, which hides the fact that our treatment might not be very, let's say, effective overall, but it might be effective for some people and not for others. And so we need to capture somehow this heterogeneity. Now, this has been difficult to implement from a methodological perspective in a robust way until, I guess, just a few years ago, where now we do have very robust methods to estimate what we call conditional treatment effects. So the way our treatment effects varies conditional to some characteristics of the individuals that they are treated. And this is now something that people use. And it is the key, really, to move from a sort of one solution fits all kind of approach to essentially personalization of behavioral intervention. And this personalization can stop at a group level. So, we just found that a group of people with certain characteristics respond better to one treatment rather than another. But we can even now reach the point of individual treatment effects. So we can actually find out for each person which solution works the best. Now, this is interesting also from a policy perspective, because clearly from a policy perspective, governments or institutions cannot design individual level policy, but they can do group level policy. I mean, they already do, in fact, in many domains. So the idea of trying to differentiate the type of interventions that you do depending on the type of topic, I think it's really interesting. But the idea of personalization or trying to tailor your interventions based on groups with certain characteristics is also interesting from an academic perspective, because if done in the proper way, it allows us to identify the specific settings and conditions in which interventions work. So they give us a bit more of a sort of ecological approach to behavioral interventions, meaning that we understand that for people in certain conditions, this might work, but maybe people with similar characteristics, but in different conditions, I mean, conditions of living, really, it might not work as the same way. So there is a lot of effort now in trying to also modify the way our RCTs are designed to capture this type of heterogeneity, because until just, I guess, a few years ago, heterogeneity was studied as a sort of postdoc thing. So you run your RCT and then just go back to the data and study the heterogeneity. But more and more people embed in their design the idea that they know they will find heterogeneity. So the way how they design the RCTs are meant to capture that as much as possible. Lastly, I mean, there's also an ethical aspect. The ethical aspect has to do with the fact that if you do, let's say, behavioral interventions without exploring the heterogeneity of effects that you have, what that might lead is the fact that the people that don't respond well to your treatment, if associated with already existing vulnerability, people that already are in a particular socioeconomic, for example, vulnerable groups, and they don't respond well, they will be double penalized somehow, because overall you will see that your treatment as a sort of on average will work, but you just don't know exactly how well it works with certain type of people. And so it will give you the illusion that something you're doing actually works, but for the people that they need it the most, is not working. And I think that's a temptation that, especially in a context of policy where you want to have some results, but also you're very conscious that you cannot just keep doing experiments and so on. At one point, you have to draw the line. Is out there. So there's also debate about heterogeneity should be considered also in terms of identifying particular vulnerable populations that need a special care. And this is something that is part of the debate between the behavioral science community and the legal scholars, that they are engaged with the legal and ethical implications of behavioral intervention. And the last point that I just want to make is that understanding heterogeneity up to the individual level, I think it's also a very good way to start thinking in more systemic terms, meaning that another current debate in behavioral science is the idea that we should be much more aware of the fact that whatever interventions we do, they have a systemic effect, an effect on the sort of other things happening around individuals. Now, this is very hard to study, very, very difficult to study. But if you have a robust estimation of individual treatment effects, we can use that using methods that in the social science we have to study a bit more at systemic level interaction of people. For example, agent-based models. So the idea that we basically have an idea of how people interacting in different contexts. These are artificial simulation, of course, because I mean, ideally, we would like to do it in real life, but this is very hard to do. Heterogeneity-informed experimental data, they can be used to calibrate agent-based models to an extent that it was not possible before. This is some of the work I'm directly involved from both sort of applied and more methodological perspective. And I'll stop here because I think I used my 5 minutes. Thank you.
But you've also preemptively answered some questions in the chat, so that's very forward-looking, Giuseppe. Perfect. And actually, on that note, I'd like to move on to our third speaker, who is Professor Uri Gneezy. Professor Gneezy is actually the Epstein Atkinson Endowed Chair in Behavioral Economics and a professor in UC San Diego's Rady School of Management. He brings to us here a long and distinguished career from the University of Chicago, Technion, and the University of Haifa, among others, and is currently a visiting professor here at BISI. Uri, Giuseppe and Serene have both talked about interventions where we might not see the effects that we want to see, or interventions might not work as well. But I hope that you'll be sharing with us about some situations where it might not just not work, it might actually cause harm. And in the field of healthcare, we have the clinician's injunction to first do no harm, but that's much more challenging and complex for us in the world of behavioral health. So please.
Good morning. Thank you, Joanne. It's great to be here. I'm going to talk about people, right? So we are people and we make interesting choices. Interesting is an understatement. For example, I wanted to talk about it later, but I thought about it now. Before I go to my annual checkup to have my blood test, I don't drink for a few days, right? Serene discussed drinking less. So I drink almost every day. I drink a glass of wine or whiskey. But before I go to the doctor, I don't do it. Now, who am I fooling? The doctor doesn't care about me. This guy that I go to sees people like me day in, day out. He wants to help me. But, if I want to cheat on the test, go ahead, right? So the point I want to make is that we're dealing with people. When thinking about behavioral health economics, as I like to call it, basically, I think about three different types of agents. The first is policymakers. Policymakers are people that try to set the agenda, what's going on. The second will be the healthcare provider. And the third, us, the people. And some of us are in more than one role, right? You can be a physician, but you're also a patient. You're also a person, right? So if we start with I think that public policy is the place where things relate very much to what was said already today. There are no simple tricks, right? So at some point, behavioral science, behavioral economics try to say, oh, look, we have a bag of tricks. We can just do something small and we'll fix everything. It doesn't work this way. Here are two examples. One is organ donation. So about 20 years ago, there was a beautiful paper showing that if you change the default on the form in which you decide whether to be an organ donor or not, you see a big difference. So one option is the opt-in. So you are not in unless you sign it. And the second option is opt-out. So if you don't do anything, you are still going to be on an organ donor. Huge differences. So if you have the opt-in, you get 10%. If you have the opt-out, you get 90% of the people saying. I read this paper as a young man many years ago. I thought, wow, great. Amazing, we solved the problem. Turns out that it's really not the case. So if you look at places that put a lot of effort, and that requires a lot of effort to convince the policymaker to change the law, places that did it, what they found is the opposite. They found that it backfires, if anything. It doesn't help. It's true that people change where they sign, but when it gets to the moment, your dear one is lying in bed in the other room, and you have to figure out, did they want to donate their organs? Now, if it was an opt-in, then you knew my loved one looked at the form and said, yes, I want to donate my organs. I think it's important to help science or other people. If it's opt-out, you don't know. Maybe he didn't see it or she didn't see it. Right? So how do I know? I don't have any information. It's someone who is in great stress, horrible situation. I have to make a decision trying to predict what that person did. Turns out the default has no impact on that. And there are many other examples. So another place where it was used is with pensions. So places in which the default was that you don't contribute, turns out people contribute much less than places where the default was that they will contribute. But if you look later on, now we have data for almost 30 years, you see no difference in actual saving, which is what you care about, asset accumulation, because I save more on my pension, but I spend more on my credit card, which is a dumb thing to do because the interest that I pay on my credit card is higher. That's just one example how things are complicated. Another example that we all went through is the COVID vaccine. Now, Singapore is unique in the world in the sense that people here trust the government. If the prime minister here goes on TV and says, look, my fellow Singaporean, this is important in order to start everything, please go get vaccinated, people go and get vaccinated. But in many, if not most of the rest of the world, so in China, in the US, in Europe, people just don't follow. People don't trust the policymakers that much. People went and decided to make it mandatory. So to force people to get vaccinated. Now, there were mandatory vaccination before. So, for example, my kids in California could not go to a public school without being vaccinated. But that was fine for some reason, which we don't really understand. Now with this one, people felt that it was rushed. There was a huge amount of fake news. People didn't believe the science. People had lots of conspiracy theories. Forcing them to get vaccinated there's no evidence that it actually increased the number of people who got vaccinated. But what we know is that when we look at data now, we see compared with 2019, now it's way worse. If you look at any other vaccine that you think about, everywhere in the world, people get vaccinated less. And if you think about what medicine did, three things are really important. Hygiene, so wash your hands before you cut a patient, antibiotics, and vaccines. And now vaccines are in huge drop all over the world. And you see measles, coming up, things that were not out there anymore. So what I'm trying to say is that we need to understand how things work before we start actually implementing them, because they can backfire, like was mentioned before. Maybe I have time, I think, to talk about the second one, and then the third one I'll talk on the second round. So the second aspect are the healthcare providers, right? So think about your doctors. How do they treat you? I can, again, my personal experience, I went to the doctor, I go to the same doctor for 20 years. When I went there at the beginning, he looked at me in a very judgmental face and said, "Oh, you need to lose weight." Okay, So what do you do if your physician is judgmental and like this? He was a skinny dude at the time. Now I go to him again. Now he's fatter than me. Now he tells me, "Uri, you need to lose weight." I know how hard it is, right? That's a very different conversation. So if your physician is judgmental, you're not going to tell them. We talked about things before. Am I going to tell him that I smoke, or other people, I don't know, that they drink, safe sex? We're not going to share these kind of things if the doctor is judgmental. So to understand the reaction between these. Other things involve incentives. So here in Singapore, when you go to your primary care physician, they also prescribe the medication for you and earn money on that. If you think that they don't overprescribe, you are very naive. If you look at the US, the physicians are being paid for service. So they're going to send you to scans that you don't necessarily need, that could cause more harm than benefit, but they're being paid for it. Or they might be afraid of lawsuits, right? So I know that you probably don't need this. It's probably, CAT scan has some damage, it's bad for you. But I know that there is 1 in 1,000 chance that you do need it. Now, if I just do the statistic, you don't need it. But if I know that if I will not send you and something bad happen, you will sue me and I will lose everything, right? So these kind of things affect physicians. Now, a physician needs to understand that they are working with people. So think about two types of treatment, and then I'll finish with this. Imagine that there is a disease. You can either give the patient one pill that will solve a problem with 90%, or a regimen that will take 10 days. They have to take it morning and evening, and will eliminate the problem with 95%. Which one should you do? Well, if you know that your patient is going to adhere to the regime that you prescribed, go for the 10 days. But if you look at the person in front of you and say, look, this person is probably not going to do it, it might be better to go at the second best, which is actually the best in this case. Understand that you're dealing with people. Thank you, and I'll continue later.
Yeah, thank you, Uri. And I hope we get questions and all kinds of responses from the floor, because I do know that we have a very mixed audience out there. We also have, I think, physicians and clinicians that are working on exactly these topics. For example, shortening the duration of our long duration antibiotics and things like that, precisely in response. So I know many people in the audience will have questions that are directly related to these topics of how we actually treat people and not patients. I'm going to bring the conversation back to Serene and ask Serene actually for her reflections or responses.
Thanks, Joanne, and thanks so much, Uri and Giuseppe, for your remarks. I think the thing which really stands out to me from I guess what all of us have been talking about is the notion of people. I really like what Yuri says, right? About he wants to talk about people. Really, it's just at the core of health behaviors. And so much of what implementation science and behavioral science and I think a lot about sort of like the confluence of the two, really is stakeholder management, right? Not just the patients, but the larger ecosystem within which behavioral change happens. And so much of that is really because of the bundle of biases that we struggle with, the ways in which we interact with the environment, and how once we are asked to make these decisions in the real world, the kinds of challenges that both Giuseppe and Yuri brought up, the fact that, oh, I can very, from a theoretical and principle perspective, say that I support organ donation. I am all for science, but when push comes to shove and I have to decide whether or not like I donate my like mother's like cornea, that becomes a very hard decision in reality. So like the idea of like principle and reality, efficacy and effectiveness. And so I think as healthcare practitioners, whether you are a researcher or a physician or a nurse in a healthcare setting, we just have to be very empathetic and cognizant of the fact that we are working with people with very real emotions, and that regardless of what it is that you've read in an academic paper, um, to be prepared that what you read isn't going to actually play out in real life. Because I think there's a lot of optimism bias when we are doing implementation in the real world, which then leads us to not expect heterogeneity, not to expect spillovers, and also not to treat people as people. Like I think the really nice distinction about patient versus people is something that I think not enough researchers take into account. I think physicians do, nurses do, medical healthcare workers do. But I think that bridge often between researching and practicing, and what comes in when we manage stakeholders isn't as obvious. And I think a center like BISI is really where we try to bridge that gap, right? Where we bring together people in research and people who practice, and try to figure a way to then make this bridge more permeable, to think really about patients as people. So yeah,
Yeah.
so stakeholder engagement.
Yeah, and I actually sort of pick up on that and say I think the other point that you made, I think which was very helpful, was also that providers and researchers and policymakers are also people. So a fair amount of the challenges are also because I think when we put in these interventions, I was struck by the organ donation example. It reminds me of the efforts that we are taking to try to think about defaults in advanced care planning. That there's a fair amount of wishful thinking, and so we don't plan for reversing those policies because the people who put them in place are so optimistic and want so hard for there not to be reversals. So the space in which people will back out of those decisions is not well articulated or planned for, and sometimes not for malice, but really because we ourselves have that bias and we want it to work so badly, we forget to make provision for when it doesn't, and then things get very, very, very challenging. I'm going to move to Giuseppe, and Giuseppe, to ask you for your reflections and thoughts.
Well, yes, thank you. Thank you to both Serene and Uri. I think it's fair to say that there is now an increased concern about the fact that you want to take in consideration people's agency in behavioral interventions much more as people would designing behavioral interventions would do just a few years ago. It seems to me, I mean, a pattern that I've seen in many social science where basically each discipline have their own simplification of the human being. So in other domains, you have, I don't know, in sociology, for example, you have this oversimplification of individuals just being shaped by social structures, and that's it, and everything comes from there. In, let's say, classical economics, we have, let's say, over-reliance on certain type of decision-making process. But also, I mean, at the end of the day, in behavioral science, we thought that just because we do interventions about biases and heuristics, people still can be strategic. People can still react to our interventions, and so that's, I think, part of the maturation process, how we think about these interventions, meaning that in most cases, you need more than one approach working together. It's not that you just have one behavioral solution for a complex social problem, which is associated with people. But in general, I have to say that my experience with the policy environment is that it's really hard because you are in a condition of constant sort of arms race, really, about interventions. So I recall my experience in behavioral interventions regarding online gambling. And here we're talking about online gambling of game of chance, so not sports betting or whatever, but playing just game of chance online. And when you try to limit the damage that online gambling can do in creating addiction, you are facing, in that case, industry. They are equally aware of what things works to push it in the other direction. And so the moment you try to implement something, they immediately counter-react. I remember that we did a number of studies and we proposed something for the European Commission to intervene. And before there was any push from the policymakers to implement this stuff, the industry representative of that sector, they say, well, don't worry, we self-regulate and we basically implement some of the stuff you tested. Why? Because they sort of cherry-picked some of the measure to gamble responsibly, so to speak, which will not then affect their industry overall. So it's a really difficult case where you have a lot of strategic actors there that they know also how to react to your intervention. So sometimes your interventions do not work or create negative effects because simply you are not operating in a vacuum where you just do something and there are no other third parties interest in doing something the opposite way, because there are. And so I think that's the difficulty that should be acknowledged. Yeah.
Yeah, I think that's very striking. I had an economics teacher once who once said that, just butchering the phrase, that ceteris is never paribus, and we try to imagine it is, and all of the work that goes through under that assumption in the real world will just never fly. I'd like to now turn that back actually to Uri. Uri, you alluded to a third example that you were going to share with us.
Yep. So I think it relates very well to what was discussed now. Changing behavior is really, really hard. So all of us, if you don't have a habit that you want to change, you're a very boring person, right? So either some negative thing that you want to stop, like playing computer game, smoking, or changing your diet, or some good one that you want to pick up, like exercise. And if you don't have something like this, you're a weird person. But if you do, then you know how hard it is, right? So often we try to do it, but it's just very hard to change behavior. There are no magic solutions. So to be more positive, what's an example of something that we try to do now? So we have a research proposal out for looking at patients that get GLP-1, so Ozempic or one of these drugs that are, in general, statistically very good in helping people lose weight. Now, the way it's done now in most of the world, not all of the world, but most of the world, is that you go to your physician and they give you your prescription and send you home. That's it. Without any attempts to change your lifestyle. They might tell you should change it, but there is no real attempt to do this. And first of all, we know that there are times in which it's easier to change your behavior. So the classic example is the soldiers who came back from Vietnam as heroin addicts. They landed in the US, stopped the habit, right? Even a habit like heroin, once you change the environment, could be done. And start taking this medication, that's something that you notice, right? You decide, okay, I'm willing to take this medication. It has side effects. I'm willing to suffer it. I just want to lose weight. So that's a good time to try and change your habits. And what we plan to do is to try and change the diet by sending people healthier meals and trying to get them to enjoy healthier food and to try and get them to exercise more, right? So we're going to send a personal trainer to people's home to show them what they can do within, so for example, if you live in public housing, maybe you can go up and down the stairs a couple of times a day. That's already a big difference for many of these people. So many of these people are obese, they eat really unhealthy, and they don't exercise. Trying to change this, that's something that we believe can help them while they're on the medication, maybe even will help them to get off the medication later on and just change the way they behave. So those are the kind of things that we try to do under the understanding that it's really hard to change behavior. These obese people really want to lose weight. They really try, they work on it, they spend lots of money, they promise themselves, they're disappointed with themselves. It's not, they wake up in the morning, that's the first thing they think about, and the last thing they think about before they go to sleep, many of these people, and they are not able to do it. This medication, huge improvement in this. But if we can also add to this some behavioral change, that could really make it more effective.
All right. Thank you, Uri. I'm going to open now the discussion to the questions from the floor. Thank you, everyone, for sending us your questions. We do have, I think, a little bit of time. So please, if you have had questions and are madly typing now, please add them. I'm going to start off actually by following up, Uri, with one question that I'd like to direct to you and then to the rest of the group as well. An anonymous attendee asks, again, in the vein of talking about stakeholder management and policymakers, from a policy perspective, there's always an urgency to be seen to do something rather than to be seen to do nothing, and that's an incentive. So, how do you incentivize then politicians to wait for your results, particularly in complex settings where the effects might take some time across different groups, knowing that they have this incentive or this risk behind them? Maybe I'll start with Uri and then go back to the rest.
Sure. So that's as a physician in the audience, healthcare providers, they know it that, a patient comes to them, stands in, patient suffers from something, comes to them, waits in the wait, and then comes to them and they don't know, we have a flu, just go home and rest. This patient will not be happy. So you give him something, right? You try to show them, oh, it wasn't a waste of time and they do care about you. And the same is true for politicians, like you said. In many cases, they are judged, many of the changes that they'll make. So if you reduce child obesity, that you'll see the results many years in the future, right? But if you do something that seems as if you help child obesity, then you'll get the credit. And I think that in many cases, you do get politicians to do something, for example, without testing. So they use intuition. Testing takes time. They just say, okay, I know what's right. And they know, when they say they know what's right, they are correct, because their incentive is exactly like the person asked. Their incentive is for the audience to think that what they did makes sense, which is, they're not bad people. It's just their incentives. We all react to our incentives, and that's their incentive. Singapore, by the way, again, is much better than other places, because I know that you have elections, but the election, it's not the bureaucrats. The government is really looking into the future, and that's why we have this discussion, because they do care about aging population. They do care about things that will happen 20 years from now. If you look at politicians in many other places, my congressperson in California, they think about a 2-year cycle in which they have to be reelected, and that's not a good thing. Maybe the best we have, but not a great thing.
Yeah, I'm going to also turn that question to Serene, who has a lot of experience, I think, on the ground dealing with politicians and policymakers here in Singapore. And we'll talk about the election another time, another webinar.
We don't have the time for it. I actually want to take that question together with another question. I think it was one of the earlier questions about whether or not the pipeline of testing in the lab and then translating that into the field is a viable one anymore. And I know it may not seem intuitive why those two questions are similar, but on Yuri's point, I do think that he is absolutely correct, which is like the incentives for politicians to act are not necessarily the same as, let's say, a physician or, healthcare researchers. For them, it really, what is their incentive? Their incentive is to show leadership. Their incentive is to show direction. And that doesn't have the patience, right, for like a 2 or 3 year trial, for instance. And so, the motivation for them is quite different. It's not good or bad. It's just different, right? But I think that doesn't mean that we haven't had conversations with, I wouldn't say politicians directly, but policymakers for sure, who do have some leeway. I mean, that same impetus to be seen as taking action, we call commission bias, has also to be an informed one, right? It can't purely be just my gut feel. And so they do have some patience for some testing and some evidence, not like for a 2 or 3 year trial, but if we told them, give us 2 months, right? Give us 2 or 3 months, we can do an online trial in a sandbox environment. So use these words, right? Because the point for them is that they don't want to take political risk, which is, exactly what is said there. And so, but in a sandbox environment, in an online environment, you are minimizing the risk because it is simulated. But yet, it still gives you some level of evidence. Now, obviously, the caveat is that whatever you test in an online environment may be efficacious, right? Because we see that it has some sort of like, not even efficacious, but like at least have some kind of a result for you to use that may not generalize in the public. It does give you some evidence that policymakers or politicians can then use to justify their decisions. And so on the question about whether or not that pipeline of lab to field is still viable, I would say that in situations where politicians are slightly nervous about a large impact or are slightly risk averse, doing something in a pilot space, doing something in a lab can give you some level of evidence that politicians can still use to make their decisions without having without sort of like rocking the boat, so to speak. And so I do think that there is still some use for running trials in a more controlled environment, precisely for the same reasons that Yuri has just mentioned, right? Which is that politicians are very unlikely to wait very, very long, but yet still want to make some kind of informed decision, such that if it does have unintended consequences or spillover effects or heterogeneous findings, we can say, oh, but we tested this in a lab. And so I think it gives you the kind of buffer that running a whole field trial may not.
And I think that gives us an idea also actually that this distinction between field and lab is not so clear now, that there are a lot of different sort of spaces in between or different methodologies, that it's not so black and white. There are actually quite a number of questions in the chat that I want to combine together and say that I think the audience is very fascinated by the idea of practically how do we incorporate heterogeneity. And the two sort of aspects of that question are, firstly, how do we incorporate heterogeneity from a methods perspective when we design our CTs? Giuseppe, specifically in Singapore, we have something called the model answer. So people are very excited to hear about specific trials or papers or projects in which that design has been implemented that they could look at. And then secondly, in practice, I think there are a number of questions about how we then take sort of a balance between this precision medicine kind of approach where we try to personalize this and actually the actual types of interventions that actually have to be rolled out at a population level in a mass way, and what are the challenges and benefits of actually implementing a more personalized approach in behavioral health interventions. So I'm going to start with Giuseppe and then open the rest of the question to the other two panelists.
Okay, so a lot of meat on the grill there. Yes, there are RCTs that can be designed to let's say capture better the issue of heterogeneity. These are usually various forms of response adaptive design of RCTs, essentially. So the idea is that you do some sort of multi-step RCTs where you adjust allocation of individuals based on the response and the heterogeneity of effects that you have, and then continuous testing with the different allocation of people in different groups that is based on this adjustment that you do throughout the data collection. I mean, it's a bit of a sort of technical discussion there, but essentially these are one way. Another way are called enrichment design, where you typically add conditions at different stages, where once you find out there is heterogeneity, to test essentially how people would respond if allocated to a different treatments that you found people with their characteristics responded better. Okay, so it's more straightforward. About the balance between personalized and let's say population level, I guess it largely depends on the type of interventions we are talking about and which domain, because in some domains to provide a personalized intervention is rather not costly, so to speak, compared to other domains. So everything that has to do, for example, these days with digital health, okay, so domains where people through digital tools, they either receive information or whatever type of interventions you're doing, basically they can be easily personalized because the delivery to each individual can be easily customized. And of course, now people that are applying even more sophisticated methods there in terms of AI that can learn from your response over time. So it will further personalize just based on your personal history kind of thing. But I think overall, the issue here is that the sensitivity about heterogeneity comes from the fact that we want to have a sort of a more nuanced approach to behavioral interventions. One example of this is a study we have been doing right now is about improving the screening uptake for a certain type of cancers. And the type of interventions that we have done to move people to do these screenings clearly have a lot of heterogeneity of effects across different type of people, okay? And we found a certain type of, let's say, interventions work better with certain type of people. And so the idea is that, okay, how we can design an optimal policy where everybody gets the best intervention given the information we have in terms of how effective it is in order to maximize. And we can compare that to a case where we give to everyone one type of intervention or another type of intervention. And so we get a sense of basically how the overall sort of welfare of what we're doing increases or not, okay? And we get a sense essentially of what is the optimal, adding also the cost that personalization might have, okay? And so we get a sense of basically what is the best strategy. So yeah, there are studies out there. I mean, there are papers. I mean, people can just maybe drop me an email. They will find the details on the BISI website of how to contact me because I cannot give references right now in this context. Okay.
Yeah, I'd also suggest that actually, those of you on the Q&A who are very interested in agent-based modeling and other technical questions can also follow up with Giuseppe separately as well. Sorry, Giuseppe, this is going to make your life very miserable. There's an unintended consequence for you. Uri, I'd like to maybe move to you. I think we're actually thanks to the variety and quality of the meats on the grill, I think we actually have a lot of questions that will actually remain unanswered today. But I'd like to maybe spend a little bit of time for each of our speakers to maybe just also wrap up with their overall reflections. Uri, I'd like to just give the floor back to you for a couple of minutes, maybe to reflect on some of the questions that have come up. I think you can see that there are a lot of questions still in the chat about practically how do we balance people and evidence, and in actual fact, what does that mean when the rubber really hits the road? Maybe I'll leave you to a couple of minutes of final thoughts.
So I think that's the last question is a great example. Think about if you're a physician, John, two people come to you. One is put together like Giuseppe. He understands AI, he understands everything. The other one is like me, I'm older, I don't know what AI is. Maybe you need to give different, remember the example with the 1 versus 10. Maybe, if a 25-year-old person comes to you and you know that they can follow the 10 days that you give it to them. If an 80-year-old person comes to you, you see that they have problem, with mobility, maybe problems with memory. Maybe you should say, well, maybe this person should be treated differently just based on this. Now, it's problematic because it could get to discrimination, which we don't want. So we know that the research shows that if you are a young woman, you'll go to the physician with pain. The physician will say you're hysterical. I'm an old man. I'll come to the physician. The physician will say, oh, that must be serious because of that, right? We don't want something like that. But we do want them to take into account how likely it is. People are different. How likely it is that this patient that I'm facing now, given all that I know about that person, right? So I know their history with me, maybe. I know the background, the diseases there. How likely it is that that person will follow what I prescribe to them. right? So that's a heterogeneity that you should try and take into account, right? And that's on the really low level. So Giuseppe talked about the big level, out in systems, how we use AI with big data, how do we get to better decisions? That's very important, but also the experience of the doctors. I think that many of the physicians, if you'll just talk with them and tell them, look, this is something that you might want to pay attention to, they have all the knowledge in the world. They know, many of them saw thousands, tens of thousands of patients in their life. They know, but they never thought about it maybe in this way. Mm-hmm. And those are the kind of things that we can help by addressing them. More generally, the main thing, I have 10 more seconds. Basically, what I'm trying to push is that we'll look at the entire system as people. The policymakers are people that have their own incentives. The healthcare provider, I'm a person, we all are, right? And we need to take this into account when we try to design a better system that works.
Yeah, and keeping our eye on the goal, which I think is more effective care for people, regardless. And I think it also speaks to the fact that we talk about technology. Technology can make things much easier for us, but if it opens up to those same biases, these are still very complex issues that we have to unpick, and there are no cheap silver bullets anywhere, or even expensive silver bullets, really. Giuseppe.
Oh, yes, I mean, I agree. Indeed, I mean, there is the need of understanding the kind of complexity that we're dealing with. I'm also, I mean, although of course I appreciate the new technological tools, I'm not, a sort of technological determinist. I mean, I don't think just, with the tool you'll fix everything. But it is true that I strongly believe that advancement in the way how we do this type of research and study advances also our understanding of basically what works and what doesn't. And it also, the way how we generate our theoretical understanding of how behavioral interventions work in real life, in complex settings, is tied up to our capacity to do studies that can capture that complexity. And so at this stage, the example of heterogeneity is a good one, because heterogeneity doesn't fall into the sort of neat groups that we might have in our head about differences, gender differences or educational differences, but it can be much more complex than that. And without the proper way of understanding this from a methodological perspective, it's impossible to grasp that complexity. I think simply our minds cannot do it. And so that's where I think now it's a very exciting and innovative time to do things. Yeah.
Yeah, and thank you also for reminding us that technology, whether we like it, is part of that landscape and part of that complexity. It's not a question of we like it or we don't like it. It is, and we work with it. Serene, I'm going to pass to you for the closing thoughts on the whole panel.
Oh, well, no mean feat.
Okay.
I'm actually gonna just use the last minute that I have to sum up sort of like some of the questions that people have asked. So I think there's a lot of question in the chat on the limitations of the RCTs, right? So we're talking a lot about complexity, about heterogeneity, and whether or not there is still room, and whether or not there's still a place for RCTs in the research world. And I like very much to think so, yes. Because I think RCTs enable us to really think about what are the conditions under which it is possible for us to have this positive effect. What is it that we have to enable to make sure that something is efficacious, right? And then for us to use that as an aspiration when we're looking at the real world to say, all right, if we really wanted to treat this problem, whether it could be mental health or weight management, we need to help people get there. That just because it doesn't work in the real life in this situation doesn't mean that it will never work. And so what RCTs enable us to do is to produce the evidence to show us what needs to happen for us to have this, this real good effect. And then to think about how the conditions can then be redesigned. And so I don't want people to leave this webinar thinking that, oh, because the world is complex, because people are complex, that we should therefore never do rigorous scientific studies. But I think the studies are there for a reason, as the aspiration, as the North Star. And then we think about how to then help and move people in that direction. So, yes.
Yeah. And I do also think that in a complex world, we don't have the luxury of saying, I don't want to use this part of my toolkit. We have to use all the tools that are available to us, depending on what's appropriate for that setting. So thank you so much to all three of our panelists for a wonderful discussion. I want to thank again the audience for their wonderful questions. I'm so sorry we couldn't get to all of them today because there were just so many, but reflecting your incredible enthusiasm for this topic. Thank you to BISI for hosting us today. Please do join us for our next webinar and have a very good rest of the week. Thank you.